So let's give a round of applause to Dr. Wiersma.
Thank you so much for that kind introduction. Thank you for spending an hour of your time with me this afternoon. It's a real honor for me to be here. I'll try to keep my eyes wide open, even though I just flew in last night it was a long journey. It was about 36 hours. It usually doesn't take me that long to get here, but I stopped too long in Atlanta to get here. So, and my apologies to the kind public health students that have listened to some of these stories during the class, and we'll maybe hear some of the same ones repeated here. But I'm again really honored that the Alumni Association has bestowed this amazing kindness on me, and I was asked to kind of talk about how Calvin shaped my vocational journey. My vocational journey, I guess, is more like it's not really a clear journey. It's more like a maze, I guess, that I went through. And so in the African tradition of where I've spent most of my professional life, I like to just tell stories. And if you can prompt me by asking questions that would help, then I'll stimulate some more stories. So I'll try to just share some thoughts. And don't worry, it's a PowerPoint, but it's just pictures. And it's just to help prompt some of those thoughts. So yeah, I was here at this wonderful institution, and I was exposed to a lot of great ideas and thoughts about how big the world was and what the possibilities were. And I think it really did shape a very interesting vocational journey, if you could call it that. I went to Wayne State University after attending this wonderful place and studied medicine. But medicine's so broad, too, I had to figure out what to do with that. My first exposure to living outside Grand Rapids, where I was born and raised, was to go to Residency, Zaire, which is now the Democratic Republic of Congo, and actually it's not too far from where I'm currently living, across Lake Albert. I was very fortunate to get a scholarship called the Reader's Digest International Fellowship to go and spend 3 months with a surgeon there, and had some amazing experiences in that beautiful part of the world. But one of the things I think that shaped the rest of my life was not just working with this American surgeon who was an amazing person in his own right, but visiting a guy from Luxembourg who worked down the road, and he was doing public health. And that's the first time I ever heard of that concept, public health. And I think what really struck me is the long queue of patients that we had to attend to every day and the surgical outpatient, and thinking what would happen to those patients when this missionary would go on his furlough, which they did every 4 years or so, go back, raise funds, and take care of family matters. And I really never got a satisfactory answer to that. And I think I thought a lot about sustainability. I had a Calvin interim on that subject. And so the concept of public health and what that guy from Luxembourg, who was also a physician, was doing in terms of training people, empowering the community to look at their own problems, that I think really struck a chord with me and made a lasting impression. I didn't have a lot of resources to pay for that trip to Wayne State, so I at one point had reached in the trash can and retrieved an application for the Air Force, and I took an Air Force scholarship to go to medical school. And that exposed me to the whole Air Force brand of public health, which was yet another one, more like occupational health really than the kind of public health I currently practice. But it was interesting, you know, again, thinking about other parts of medicine that I wasn't really exposed to in my academic training. I spent 3 years in Germany with a C-130 squadron that kind of took me all over the world, and including the first Gulf War, and I learned about occupational medicine, also about prevention. And prevention, again, I think was that thing that seemed most fascinating to me. So I was actually in the Gulf War when I applied to Johns Hopkins, and I was going to stay with the Air Force. But my wife was getting very sick of these long deployments that was going on, and so we left and spent all our savings to go to that not so cheap institution, but got a good experience there studying public health, and I did the preventive medicine and public health residency there as well. that launched some other things. I was fortunate to do a rotation as part of my residency in with the World Health Organization. They were going to put me in Geneva, but they ran out of money for a 3-month rotation and offered me a 2-year job. So that's not a bad trade-off. Yeah, it's a good launch pad. So I went to Zambia with WHO and worked on diarrheal diseases at the time. And it's still mostly true, sadly, I guess. Diarrhea, acute respiratory diseases, malaria, HIV are the leading causes of death for children. So I was fortunate to work on diarrheal diseases and start an acute respiratory infection program and then do some HIV work there as well. I do prefer questions, so if any of this stuff rings a chord, if you have anything you want to ask me about, please feel free to stop me. I had an unfortunate incident happened to me when I was in Zambia. I was involved in a near-fatal car collision, and that stimulated some more public health later in my career. But in my own case, it took me out of Zambia, and because the government doesn't have much of a tolerance for risk, and they were concerned that the eye for an eye, tooth for a tooth principle would apply. And since there were fatalities involved in the crash, even though I wasn't at fault, they basically dismissed me from my tenure in that job. So I found a job in Eritrea. Eritrea had just come out of a long history of conflict with the U.S. and Russia, struggling for independence. And we came in about 2.5 years after they had won their independence. And it was a real breath of fresh air to work with a community that was really empowered to follow their own plan, especially for public health. They knew where they wanted to go. I'll never forget a large European Union delegation came in with a lot of money, as happens almost every day in African countries, a donor package, and they said, "Hey, we want to give you all this money." And the Eritreans said, "No, that doesn't really fit our public health priorities. We're not interested." And I thought, wow, this is good. These guys, they know where they want to go. And so I was very fortunate to work there for a while. That was with the USAID, working across the health sector. As things happened, it wasn't much of a school. I had a child with some learning disabilities, and we needed to move on from Eritrea. They wouldn't give visas to teachers, so there wasn't much of a school. And the teachers there said, you really should get out of here for a while. So we went to the U.S. I sent out form letters to state health departments. Thought, well, why don't I give domestic public health a try? And was lucky to get picked up by the state of Florida as the deputy state epidemiologist. For just enough time to learn what that job entailed before the epidemiologist left, and I found myself in that lead role. And I stayed there for about 6 years. It was very much an adrenaline-filled ride. There were outbreaks left and right. I think I had been there a week. My boss went on vacation, long-deserved rest, and we had a large outbreak of St. Louis encephalitis. And I was called to give an on-camera live interview, and it was with a very famous morning television producer, a national syndicate. And coming from Africa, I didn't know who these people were, and I kept asking, for them to clarify what was a household name, and they thought I was crazy. And I just explained to them, look, I just came from Africa, I don't know who you guys are, but I think it helped me talking to the press, because I wasn't very intimidated, because I didn't really know my audience at that point. And I was trying to compare malaria to St. Louis and say, well, this really isn't that big a problem, and that didn't work out so well either. But it was a learning curve, but I learned a lot. We had a lot of firsts when I was there. Again, that adrenaline junkie ride. It was after the St. Louis encephalitis, we had a large West Nile outbreak. We had the first ever case of mad cow disease, new variant Creutzfeldt-Jakob disease. The anthrax attacks occurred on my watch in the post 9/11 world. We were all worried about, and that was quite a good learning experience. I was telling the public health class earlier, one of the things I'm most proud of during my time in Florida is that we got a lot of post 9/11 bioterrorism money. And I had been reading an article about how they're doing field epidemiology training in Africa, and I thought, well, that's exactly what we need in Florida. So it was kind of the reverse global health problem solving. So we took a lot of that bioterrorism money and we created the Florida Epidemic Intelligence Service, where we trained epidemiologists for county level work in Florida. And that program, I'm proud to say, is still ongoing. There was a review of it that was published in Public Health Reports that showed a retention rate of over 90%. So we picked people that were kind of master's level trained, that really had a high motivation to stay in the state of Florida and work at county public health level, and trained them in a 2-year kind of practical on-the-job training program. And it seems to be working there as it is in Africa. I guess after 6 years of that adrenaline rush, I needed a break, and so I saw a job in Geneva, Switzerland, and I thought that's just too good to be true. And as is the case with those kind of jobs, it was, they had already picked someone, but they had advertised the job to make it good for HR, I guess. So, but the person that the job was designed for withdrew at the last minute, and so I got hired into this job. It was a CDC job, but my first job with CDC wasn't in Atlanta. It was actually on secondment to Geneva, and I was working on childhood immunizations, but as the hepatitis guy. So working on hepatitis prevention through immunization, and had a lot of very good experiences, including being part of the global polio control initiative that unfortunately is still going on. Should have been done by now, but maybe someday soon we'll get there. And spent 3 years that time with WHO, traveling around the world, and then continued with CDC. Went back when my wife took a job in CDC's Disease Detective Training Program, the EIS program. So I went back to Atlanta to the headquarters of CDC and worked there for the hepatitis group. Hepatitis at the time, I think it's getting a little bit better. It was kind of a not very well understood or appreciated set of diseases, and that was primarily the problem, because all these different viruses, and so it wasn't appreciated what the true burden of disease was. So we started a huge global burden of disease effort to try to catalog that by reviewing the world's literature and doing disease modeling to kind of show that the burden of these diseases, hepatitis A, B, C, D, and E, is actually one of the top 10 killers in the world. And there's been a series of papers that have been coming out over the years, a big series in Lancet a couple years ago, and one more that's in press now that demonstrate that. And fortunately, I think that evidence has been driving pharma, driving public policy. There are now over 100 molecules in clinical development for treatment of hepatitis C. I don't think that would have been possible if the global burden hadn't been seen as such a big issue, because pharma doesn't invest in, orphan diseases too often. So that was an interesting part of that work. Guy who replaced me in Geneva couldn't stay very long, so after 2 years they were looking for someone else to go back, and I said, well, I'll take that hardship, I'll go back to Geneva. And this time turned it into from an immunization program, recognizing all the new work in treatment, turned it into what became the global hepatitis program. And that was very interesting, working with patients suffering from liver disease, the advocates, who had finally kind of banded together. Unfortunately, unlike other diseases, they're ex-drug users, there's people that got it from medical procedures, you're dealing with different viruses, different risk factors, and so it wasn't a clear advocacy group for this set of diseases. But they were able to organize themselves and get a resolution to put before the World Health Assembly, which is how you do policy work at a global level in WHO. And that first hepatitis resolution has now been renewed twice, and starting to see some funding flow behind it to prevent global hepatitis. think 7 years of skiing was more than anyone should have to endure, so I decided it was time for a nice tropical assignment, and left Geneva and went to Tanzania. And that was to pursue, again, one of my first loves, which is training epidemiologists. And we called them disease detectives because I think, as I told the epidemiology students today, I think epidemiology suffers from its own name. I mean, no one knows what epidemiology is, so we just call it disease detectives. And governments in Africa really embrace this because they're used to having experts come in, analyze their own health issues, and make decisions for them. When we presented the issue of working with them to develop their own cadre of disease detectives to look at their own health issues, make their own priorities that weren't based on donor dollars, that really resonated with them. So we started this field epidemiology training program, or the disease detective training program for Tanzania, and had 3 wonderful years there, looking at all kinds of things from road traffic injury to the first ever dengue outbreak in a major African metropolitan area in Dar es Salaam, a whole host of things. And again, risk of repeating myself, one of the things I'm most proud of is that some of our residents that we trained were able to go to West Africa and be part of that initial response to the Ebola outbreak. So I think the fact that you have Africans now becoming experts helping out in countries outside their own country is a great proof of concept and something that I was very happy to see. Kind of in between Tanzania and going to the next assignment, I got called. That's not even Ebola spelled correctly, sorry. Yes, please.
What type and level of training did these disease detectives that you were training in Africa have before they came into your program?
The ones we took, let me just step back a couple steps. The whole concept of the training program that we promoted was based on the one started at the CDC in Atlanta called the EIS program. And that's 55 years old now. And that's a pretty high level program, really taking doctoral level people, mostly MDs, some PhDs, some other vocations come into it. And they put them in a 2-year program, mostly hands-on, but some didactic experience as well. So we follow that model in Africa. We had less physicians because there's less to go around. We had some laboratorians, we had some nurses. Clinical officers are a key health profession there. We had a few of those in there as well. But I think what we learned from that experience is that maybe we were shooting too high. And so again, I was explaining to the class earlier, we're now coming up with this concept of a training pyramid that maybe we only need a few people trained kind of at that level, like the doctoral or master's level in a 2-year intensive program. And we need some more people more at intermediate level. And we're thinking maybe a year of hands-on training would serve them well. And then we have a basic program that pretty much is just 2 didactic weeks with a several-month program where they have to go back to their facility and look at their own data and try to describe a problem that they've come up with and then present it back. So we've come up kind of this basic, intermediate, advanced model now. It's still early to see whether that's what's needed, and I think these things all have to be tailored to the country, but it's a good observation. I think the models don't necessarily translate, and the needs of the country, may dictate a slightly different approach in different places. I think I'd remember how to spell Ebola after being there for so long, but I got asked to lead to go on a secondment from CDC to the DART, the Disaster Assistance Response Team, which is the U.S. government's way of responding to usually earthquakes, floods, and other kinds of disasters. Actually, Kelvin Grad is running that whole thing right now. Conendijk, I can't remember yeah. And so they hadn't really had a model of public health emergencies until West Africa Ebola came along. And so in this case, they decided they would take on medical people to co-lead the efforts. I was the leader for Sierra Leone in the 3-country effort, and it was at the peak of the epidemic. It was about five weeks in September, October. And I have to say that was That was a very humbling experience, not only to see the devastation of Ebola as a disease itself, but how it can completely shut down the health services. And I think what was most impressive from my public health eyes is the excess mortality, the non-Ebola excess mortality that was experienced by the country, because health workers just fled their jobs. And you know, I'm not blaming them. I mean, they were very vulnerable. They were at risk, and they were taking a higher toll than any other subgroup, I think. But basically, when a case showed up, most of them, if they didn't have appropriate training or the personal protective equipment, they would just leave their jobs. So when I got there, the pediatric hospital had been evacuated. I mean, they just left. One day, they saw a couple patients that turned out to be Ebola positive, and they left hundreds of other patients still hooked up to their equipment and their IVs and deserted the hospital. I met two young German doctors who had to figure out how to discharge all those people, shut the place down, but it remained closed for several months until we could figure out a way to triage people coming in and separate the Ebola and non-Ebola cases and assure the healthcare staff that they could take care of people safely, which was a huge challenge. But when I got there, it was really chaos. We didn't have a strategy as the U.S. government even how to help. Donor support was very uncoordinated. They just dismissed the WHO representative, who's really supposed to be the voice of public health at the country level because of lack of leadership. And that was the same with Liberia, Sierra Leone, and Guinea at that time. But quite an interesting experience. And then Uganda. I decided it was time for something different and took on the management job I had only dreaded. And I'm now the country director of a group that were about 130 of us in the CDC Uganda office, 20 expats, the rest Ugandans. We're mainly an HIV/AIDS prevention program, but our genesis actually goes back to Ebola in Uganda. Uganda's had many Ebola and Marburg outbreaks over the years. And so CDC's had a long involvement looking at that, and looking at plague, looking at other mostly infectious diseases. But now we've actually got a pretty broad portfolio. Again, most of the money coming from HIV, but we've just received $22 million for the U.S. government's global health security agenda, which is going to really broaden our ability to assist the government of Uganda to prepare for all disease threats and do workforce training like the disease detective work I talked about. So I think I've talked enough about my odd career and how I went from Kelvin here. I'd really like to answer questions or maybe have you stimulate some other stories. Please.
So you're talking about those training models that you guys were creating. I was wondering if, like, how much of your training for the more advanced group consisted of training to be teachers to try to create a more self-sustaining model?
That's a great question. That's, I think, why we like this pyramid model, because we think that each level should have some teaching role or at least supporting role for the level below them. I guess the basic guys are left with no one to teach, but that's probably okay because their skill level is a little bit lower. But so that's kind of what we're envisioning. But the key is, Africa's got academic programs. You can get degrees in public health, but virtually none of the traditional academic degrees have a strong field component. And so the problem was we found people that would leave academia and really not be able to function very well in practical public health situations. And so that's where the genesis for this approach started. And so it's very much based on mentorship and teaching, and that's like 24/7 part of it. Sir. There, sir.
So thanks for being here. Tracy Paris. I teach in the International Development Studies program at Calvin. So I'd be curious, in the different countries you've been, Eritrea, Zambia, Tanzania, Uganda, what's the government's interaction with a lot of these public health initiatives, and what do you see as really helpful partnerships with governments and how they've worked what things have you know where you've seen the government's just shot itself in the foot on some of this stuff?
Yeah, that's a very insightful comment. I really contrast WHO and CDC's approach. WHO is a membership organization. So the countries are members, and it looks and feels a lot different when you go in as a WHO person versus a CDC person. As a CDC, we're bilateral. It's U.S. government and that country. And U.S. government, we tend to push a lot. You know, we got a lot of money. We know what our agenda is. We have to report to Congress on things. So the collaboration with the government, again, looks and feels different. I would say in all cases, we say that we're there operating on the behest of the government. We're there to build capacity and to strengthen government institutions. I would just say, maybe off the record, no, I can't do that with a mic on, but I think we maybe don't do as good a job when we're a U.S. government in doing that. And again, it's because of some of the accountability. And on the other hand, we get a lot of success that WHO doesn't get. WHO is very collaborative to a fault. You know, we're always talking to the government, and government feels very comfortable talking to WHO about everything. But in terms of results and action, there's a lot less of it. So I think it's a balance, you know. What we're seeing right now with our large PEPFAR-funded HIV/AIDS program is that the money is exceeding the capacity, you know, of these governments to absorb it. It's hard to find the counterparts to work with. So we end up funding them through an NGO, and we're like working with ourselves. You know, we give a partner organization a bunch of money. They put someone in the government to strengthen the government. We're working with those people. At the end of the day, when our money goes, those people go, our money goes, what's left, you know? So this is a huge, huge issue.
I'm just wondering if you could talk generally. Were you planning on talking about HIV/AIDS in Uganda at all? You sort of stopped when you got to Uganda.
I would love to talk about that. Thanks for, yeah.
Yeah, I mean, I'd really like to hear, so you've been there several years now.
No, I'm still a newbie. I've been there less than a year now.
Okay.
But I'm super excited about it. I have to say, I'll just be very frank. I was not a big fan of the PEPFAR program in the past. It was just too big for me.
Just describe PEPFAR for those who don't know.
PEPFAR is the President's Emergency Plan for AIDS Relief. That was started in the Bush administration. Huge funding stream for global HIV/AIDS. What its objectives were hard for me to get my head around. I think that's why I struggled with it. It was just so big and it was so everywhere. It was doing everything for everyone. You know, because everyone said, well, I want part of it, I want part of it, you know. So in the end, we were doing human capacity building, we were doing AIDS prevention, we were doing a little bit of AIDS treatment, and then this, that, and the other thing. I mean, we were doing cervical cancer screening. What has that got to do with HIV/AIDS? You know, it was a great thing to do, but it wasn't HIV/AIDS prevention. So Ambassador Birx, who is now the U.S. government's lead on HIV/AIDS prevention, has taken PEPFAR to its latest iteration, which is called PEPFAR 3.0, and said, we can't keep spending all this money and seeing a small decrement in new cases of HIV. The out mortgage is just too big. We can't afford it. Because, you know, the government's been very generous, the U.S. government, but, you know, to sustain that, it's just not, it's not sustainable. So working with UNAIDS, the UN group that looks at AIDS, we did some modeling and we said, what would it look like if we really intensified our efforts? Could we drive the slope of the incidence curve down in such a way that the costs would be much less when you added all those out-year costs? And so that became the basis for our current HIV global strategy in the US. And the UNAIDS goals now call for achieving 90-90-90 by 2020. The first 90 is that we identify 90% of people living with HIV. So we've got to find them first. That's not easy. It's not trivial. It costs a lot of money. And the farther you get along, the harder it is to find the ones that are left. So that's a huge challenge. Second one is of those 90% people we found their HIV, put 90% of those on antiretrovirals. Because we know that then they can't transmit it, so it's effective prevention, plus it's good care. I mean, they won't die. And then the last one is, now that we have tools to measure virologic suppression, 90% of those will be virologically suppressed. So I was at WHO when we had the, what was it, the first AIDS treatment goal, which was getting 3 million, 3x5 initiative. Getting 3 million people on antiretrovirals globally. I mean, we've almost got 1 million on antiretrovirals in Uganda alone right now. So it's staggering what you can do. And this is why I'm getting so excited about it, because I can actually see the end of the outbreak now in Uganda. This is all about outbreak control now. It's not about doing everything for everyone and, making us all feel good, which, that has its own cost. So now we're not doing cervical screening, cervical cancer screening of women in Uganda with our HIV/AIDS dollars, because we can't do all that stuff. We've had to decide what's core to stopping this outbreak. But by doing that and focusing our resources and better defining the epidemiology of the outbreak, I seriously think that we can stop this outbreak in 5 years. And I couldn't have said that 5 years ago. There's no way. But I think we have 80% of people already identified in Uganda.
I need to hear a little more on why you're calling it an outbreak since it's been there such a long time. Is it kind of a resurgence now or something?
No, it's just a classic disease outbreak like any other. For some reason we didn't like that term or whatever, but it's an infectious disease. It's subject to the same epidemiologic dynamics as any other epidemic. We just weren't treating it like that and applying all that knowledge we had from other outbreaks. Nothing different, no. It's same thing. It's just, I think, how we're viewing it and how we're applying our knowledge and the tools and the evidence to control strategies. So right now our strategy is finding those people, treating those people, making sure they're virologically suppressed, and then still doing combination prevention, which is mainly circumcision in Uganda. You have a very uncircumcised population. What you might not know about circumcision is it's like vaccine. It costs us about $60 to circumcise one Ugandan man. That has a 60% lifetime efficacy. If I told you I had an AIDS vaccine right now, I could sell you a dose, a single dose vaccine. One dose would prevent HIV for your entire life, albeit at 60% efficacy. And we have vaccines like that. Actually, the current malaria vaccines run around 40, 50. It's not that good. I mean, there's all different trial data coming out. But so 60% efficacy against HIV, that's not bad for $60, lifelong. So that's one of our key strategies. So we put all that together, and I think we can really stop the outbreak.
Yeah, I'd be interested in your perspective on kind of parachurch organizations and kind of the role that they would play in public health. There's a lot of fundraising going on around clean water, but to use and leverage them for improving public health in developing countries?
Well, Uganda, I don't know who remembers Idi Amin? He kind of ruined the whole health system in Uganda. So when big investments came in from the US government and other donors, it was all through these faith-based organizations. They were the providers of health care. They kept the country going in terms of health care. And even up until today, I would say that almost all of our investments are going to, well, the majority of our investments are going to NGOs, and the largest percentage of those are faith-based NGOs in Uganda. So they are providing a huge segment of the health care to the Ugandan people. And they're doing it at a level of quality that's much better than the government hospitals can do. Fortunately, the government's coming up. It's been a long struggle since Amin's regime dismantled everything, and people left, equipment left, facilities were degraded. But they're coming up, and we're starting to try to shift some resources, try to think, you got to work with the government too in their facilities if you want a sustainable program. But before, there were really no government facilities to work with. So they've been coming up slowly. But they play a huge and vital role in the Uganda response. And it's very different than Tanzania, where I think it's less of a role. So it's very country dependent. But long and strong history of faith-based organizations providing health care throughout the African continent, but especially in Uganda.
So when you say that you partner with them, you're basically training workers in an agency to provide the kind of services that
We
you recommend?
basically just give them money.
Oh,
Yeah, we don't train them. Well, most of our training is with government sector. We do what we call technical assistance investments with the government, and we do direct service delivery through NGOs. So we're grant making. We give them, we get $214 million a year just at CDC to give out to different organizations for the HIV/AIDS response alone. And USAID gets almost that amount as well, and most of that goes to NGOs.
You mentioned, like, I don't really recall the term, it's something retrovirus, like for treating HIV. That's a new term to me. Is that kind of like a little bit more than a vaccine and kind of works like an antibiotic for viruses?
You got it. Yeah, you've answered your own question. That's perfect. Antiretroviral therapy, just it's like antibiotics, but they're antivirus therapies. They weren't too good years ago. They're getting a lot better. And as a cocktail for HIV, you need more than one. We give 3 drugs. The other thing, so they're highly effective now. The other thing that's really great is used to be all these different pills and dosages you had to mix. Now they're doing what they call fixed dose combinations. So they kind of put it all in one pill, make it easier. So a lot of our future challenges are going to be adherence. Like if you have a chronic disease and you feel well, how motivated are you to take that pill every day? Not so much, right? I mean, even when the doctor gives you antibiotics and says take them for 14 days, how many days do you really take them, right? So people tend to, that I'm over the most of it. I kind of, so this is a common human experience. So we have to think of ways to stimulate adherence. So we're thinking of community groups, support groups. Another big thing is just getting those drugs. Right now, you have to go to the clinic. You've got to sign in. You've got to wait in that awful queue there, in the hot sun or whatever, to get your next 1 month supply. We're trying to make it longer, so maybe you get 2 months or 3 months or 4 months. But now we're thinking, is there some way that we could have one person go collect for 10 people? But then there has to be some accountability for that too. So they would collect, but then they'd have a group, and they have to all sign in and make sure, do some of the things that we would do in the clinic visit, but make it easier for the person who's still trying to tend their fields or take care of their children or all the other things they have to do to enhance the adherence to therapy. Because we know if you stop taking your drug, go on a drug holiday, drug resistance starts, opportunistic infections can set in. There's all kinds of bad things that can happen. So it's in everyone's interest that we keep that going. And unfortunately, until we find the cure for HIV, it's lifelong therapy. So you got to take those ARVs forever. So the other thing we're trying to do is just equate it to hypertension or diabetes or something. See, this shouldn't be stigmatizing. Just because you have HIV, you're no different than someone with hypertension. You just got to take your pills every day and you'll be healthy. And, let's leave this stigma stuff behind. Unfortunately, there's still a lot of stigma and discrimination.
How involved are you with the community around, concerning education, or how deep is your relationship with the community that you're working with?
Well, a lot of our work is, again, through these intermediaries. So we're hiring the NGOs to work with them. Another great thing that Ambassador Burke's put into play is something called SIMS visits, a site improvement monitoring system. They're mandating now that we go out quarterly and visit the people we gave money to. It seems a little obvious, but we didn't always do that. You give money and then we kind of walk away. Okay, they must be taking care of it. So this is getting us to the community to see how things are really going. And we've got all these different indicators we're tracking now. community involvement, looking for key populations, how's their outreach and linkage with the community. And we're going out sampling every quarter some of the recipients of our assistance, and we're looking at their performance. And then we're doing a dashboard, so we got this red, yellow, green kind of thing. We can see where they're doing well, praise them, build them up. Where they're not doing so well, try to strengthen them. And if they're got some reds in there, we're back in 3 months to check them again, make sure they come back up to compliance. But again, this is a challenge is to get to that community level, right? There's communities, there's language barriers, cultural barriers, distance barriers. We still have some areas of Uganda that I can't go to unless I'm wearing a flak jacket and a helmet and have 2 armored vehicles. It's not the kind of, a good way to do public health when you're out there dressed. First of all, you look ridiculous. And second of all, it's just hard to do the work. So, but I think that's a lot of their challenge. And I have to say, going back to Ebola, that's where we failed. We should have had anthropologists, sociologists, all those kind of people on the first teams that went in there. It was all about burial practices, community practices that we didn't understand and appreciate. And you can't do that stuff 4 months later. You got to do it right at the beginning. And that's the great thing about public health. It is multidisciplinary. But sometimes we're still slow, even incorporating all the right people on these teams.
So I want to bring you back to Calvin in terms
Calvin.
of thinking about how did your undergraduate career prepare you for where you're at now or influence you maybe, but also then thinking about our current students, what are some words of advice you have for them in terms of things that they might want to get involved in, practices that they might want to participate in, skills that they might seek out, etc.
Yeah, thanks. I'm just a real fan of the liberal arts approach in general. I just think the diversity. I was saying earlier, I think the English department gets much credit for doing good public health preparation as any other department. I mean, communication and the ability to write concisely and convey ideas is so important. Really struggled in Tanzania. Julius Nyerere, the father of Tanzania, was a visionary. He united that country with Kiswahili as a unifying language. But it came at a tremendous cost. They don't get English until secondary school, and most people don't get to secondary school. And I struggled for my 3 years in Tanzania just trying to get them to communicate and write. Unfortunately, we never published a single paper on any of our very interesting epidemiology outbreaks. I think, that's not a complete failure, but anyway, going back to the breadth. So I think, Calvin just gave me such wide exposure to so many different things, and seeing how all those things are interwoven, especially in a discipline like public health, was very, very helpful. The interim program, again, is such a rich way to then take time out from your usual things and really explore something that you maybe never thought of before. And I think I mentioned that one interim I had talking about sustainability and how to feed the world and all these kind of things, and the big thoughts and those kind of things I think were very stimulating and very helpful in my own career development, and just trying to think what to do. I'm probably not unlike a lot of other people. You don't know how big the world is. I didn't know all these different disciplines could be studied or practiced, or I knew the basics. I had a grandfather was a dentist. I had a father who was a social worker. I had a mother who was a nurse, and I knew a few career options that were available to me. But Calvin really expanded that in a very unique way, I think. And not to put my wife's education down. She's a German-trained physician, but they're very much, you choose medicine very early, and she didn't have the benefit of all those other wonderful things that she studied medicine. It was all medicine. Fortunately, it was shorter and it was cheaper, so there's some advantages of that. But there are some disadvantages too.
So what are words of advice for our students currently?
Take it all in. Maybe that major is great, but I think, getting all the other things that you can get besides the major, and really looking for the practical experiences. I think the alumni community is great. The student body is diverse. I had some really fantastic and unusual summer opportunities. did some research here on campus with the science department. I was able to go to Oak Ridge National Laboratories through the science department and do some science work that way. And so I think the networking and just the range of opportunities is great. You know, thinking of the big universities that do have multiple major offerings, to me is still not as rich as a smaller place like this that has things like interim and has all the different credits that are required for a liberal arts degree.
10, 15 years ago, Uganda had the reputation for having one of the best AIDS prevention programs in Africa, but also in the world. What were the key aspects that made AIDS prevention better there than in many other places?
Well, we were just talking about that. Professor Kirsten and I today, I'm still learning the history of Uganda and its HIV, and I'll tell you, I've heard that statement. We've expressed that, but there seems to be some revisionist history going on too. And I've also heard people say, "Oh, that didn't really exist. That was kind of made up." And some of those are fellow Americans who maybe didn't appreciate that particular approach that was used back then. But as far as I can tell, there was something very successful there. I'm just not sure it's documented that very well. We were saying it'd be nice someone put that history together, you know? Some of those lessons learned, sometimes when you're in the middle of battle, you don't stop and learn the lessons, and you just keep going to the next thing, the next thing. I think we're on that next thing now, and we've totally abandoned prevention pretty much. And now it's treatment as prevention, which isn't really prevention, you know? And by all accounts, there was something that seemed to work there in Uganda. But in my, my short tenure there, I haven't really seen it documented very well. And I haven't been able to go and put my finger on a document and say, yeah, that's the part, let's invest in that. There was something here that we need to fan that flame, you know. So I don't know, maybe in a year or two you can ask me again, I'll have more insights, but.
Back to Uganda again, away from Calvin. Can you talk a little bit about the change in pricing of the antiretroviral medications and how that's influenced them? And who actually pays for it?
Yeah.
And the sources maybe of where you're getting it.
Yeah, that's a great issue to raise. Fortunately, overall prices have come down quite a bit. The Minister of Health just called me out the other day in Uganda on a talk. He said, you should be spending more of your money on drugs made in Uganda, because now there's a company called Quality Chemicals. So I asked some questions about Quality Chemicals, and they don't actually manufacture they're a packager. They buy the materials, they bring them to the country, and they manufacture pills, basically. They're not pre-qualified, so we don't know what their quality is. So I think that's a big issue when you talk about pricing. We have to somehow maintain quality. We want effective antiretrovirals, right? This whole problem of fake drugs is a global problem now. And so you have to keep standards high, and you have to reward clinical development, right? Because that comes at a price. I was in the vaccine field for years and years, and you know, Indian manufacturers are great at producing something, but they don't do the R&D, and then the companies that are doing the R&D are screaming foul because they say, well, you know, they didn't bear the cost of that. Now they're just reaping the benefit of our R&D. So all those things have to be balanced. The other pressure we have now in HIV for these antiretrovirals is we want to put more and more people on them. But we're also changing the bar. You know, we used to use CD4 cutoffs to decide who would get on them. Now the START trial has released results saying that everyone who's HIV positive would benefit. Not only that, but WHO has come out with a new recommendation that says even people that aren't infected but that are high risk would benefit from preventive pre-exposure therapy. PrEP, we call it. So that's even more people. So now I can't buy enough doses with the fixed budget I have. Our budgets have been pretty flat for the last few years. So I'm hoping that we can drive the price of drug down. That's the only way we're going to get to the finish line. So I just answered your question with more questions, I think. But we have to figure a way to, forecasting is another big thing. Drug companies say, if you can tell me how many doses you need for 10 years, then I can bring that price down. So we need better epidemiology, we need better forecasting. We say, we can definitely get this many people on drug, and then I think that will help pharma deliver at a better price as well. And we haven't always focused on that very much. But I think the future's good. The other thing is we gotta make the case as advocates, the buyers, saying, look, we're in this for a long time. These people are going to be in lifelong therapy. Let's count them up. You can figure out your profits right now and get your accountants working on that, and let's get to the bottom line. Because if the price stays too high, then I'm not going to be able to buy it. We're not going to be able to do the job. The program will fall apart. So somehow if you bring all that stuff together to try to drive down price. It can't be just the supplier or the buyer working independently on that. Just by the way, sort of stimulate some thoughts. Bill Gates and the Gavi Alliance, the Global Alliance for Vaccines Initiative, have really done some innovative work looking at financing, long-term financing, like saying, what if we pay a base price and then get countries to pay, pay the fluctuating part, just the tail end of it. So we can share costs better and they can start bearing their burden, but then we kind of bear the R&D part of it. And I don't know, but there's some really interesting work on global vaccine financing that they've been doing. I think that's very promising.
Because of the stigma behind HIV, what is the CDC's approach to testing? And is that country dependent, or do you kind of have a set policy?
Yeah, we always work on the government's policy, so we follow the Uganda policy, but of course we help them write their policy, so we influence their policy too, so we work both sides. We're really struggling with this right now because the minister himself, Minister Eliota, was involved in the HIV epidemic 10 years ago. He's medically trained, but now he's very much a politician, as a minister would be. So he has a constituency he's responsible to, needs to get reelected every couple of years, whatever. But his concept of testing is 10 years back. So I'm working with him on this whole policy thing because they're still using this mantra that everyone needs to know their status. Well, that was good 10 years ago when we didn't have many people tested. We needed to test people. We found 80% of the people already. So now what I'm seeing when I go out on those SIMS visits, when I go out and look at my own data, which is, again, a really important part of what we do, is I'm seeing the yield is dropping like a stone. So every 100 tests, I'm finding less and less positive. So I'm spending more and more to find that one case of HIV. So I'm telling them, Mr. Minister, we've got to have a new policy. So I'm getting our people to think about policy briefs, the evidence to, how can we think of innovative strategies to change testing policies to really focus on finding those people. So we're trying to drop that mantra of everyone needs to know their status to say, we need to find the people that are at risk and just do targeted testing. But it's a huge shift, and things don't move that quick in that environment. You spend so much time getting that message out, they go, wait a minute, I'm saying what you told me to say. So yeah, we told you that 10 years ago. Now we're trying to tell you to say something else. So we need modelers, we need advocacy experts, we need economists to look at this problem, figure out how can we find that remaining 20% of people living with HIV. We can't do it using the old approach. It won't work. We won't be able to afford it. So we're actually struggling with that right now. We're trying to do a policy review and try to engage all the stakeholders, do all the things you need to do to get that slow change in policy for HIV testing.
Sorry, and I think I'd just like to follow up on that, and I'm not sure that's what you were asking, but I'm interested in this too. The thing about the stigma, and how do you actually, so somebody comes and they're tested, how are they made known that they have it? I assume if you're only catching a few out of 80 tests, and a lot of people are getting tested, and they don't have it, and they don't have it, and so it's no big deal. But how are the people single out, this is more of a sociological thing, right? But how are they informed that they have it and that they have to take this, and what are the stigma situations that they suffer now?
Yeah, and I think we've dealt with that a lot in the U.S. Well, we've dealt with it a lot in Africa too, stigma and discrimination, but I don't think we always appreciate how hard it is to get rid of it completely. I mean, you just walk into that clinic. If you have to go there every few months to get your meds, all your neighbors know, right? Why are you going there all the time? You know, what's wrong with you? Oh, yeah, you must have HIV, So you have to think of ways to get around that. I think maybe in the U.S., you can get your drugs by mail or something. I don't know. There's different approaches.
Was that still a big problem?
It's still a huge problem. And especially if you're a man that has sex with men. I mean, this is a country where we just had a piece of legislation that said you could be locked up or physically hurt for that practice, and we're trying to fine you and protect you and offer you something. But how do we do that without putting you at risk, And one of our partners was reaching out to young Ugandan MSM, and their office was raided by the police, and all the files were taken. I mean, so we got to even think about that, data security, and how do you run a clinic, and then we used to have nighttime clinics for the female sex workers, and then that didn't work because sometimes the solution creates more problems. So it's a constant struggle, and I don't think. Some people say, stigma and discrimination in Africa is not like it is in the U.S., but it's very much there. And I think it's still very underappreciated. Just a couple more.
I think you might have touched on this a little bit with this question, but is there something about Uganda's culture that perpetuates the outbreak? Like you said,
Yeah, so the question is, there's something about the culture in Uganda that perpetuates the outbreak. I think it's similar to other countries. I mean, we know the risk factors, and the same risk factors exist in Uganda as any other country, maybe in different relative proportions. For example, going back to homosexuality, we don't even have good estimates of population size. We're trying to do that epidemiologically, but that research is fraught with peril for the same reason we just talked about, the stigma and discrimination. We've been able to do that in the city of Kampala. We have something called the Crane Survey, but we tried to introduce that nationwide using some new techniques, NSUM network. It's a technique where you ask someone if they know someone, and then you use it like a modeling technique.
Like snowball sampling?
Something like snowball. I think we abbreviate NSUM. I just can't think anyway. But yes, similar. But we couldn't get that past the Ugandan government. They thought those questions were too sensitive in an election year to ask the general population. So that got shot down. So not knowing the size of the pool of the risk factors makes it hard for us to target some of those things. But otherwise, I don't know. I mean, it's a unique culture, but our culture here is unique too. I think it's just like every public health problem, we have to adapt the solution to the context. And so, like you said, culture is a big part of it. We got to understand it and apply what we know about it. Maybe one more?
I think we can take one more.
Yes, please.
How do you see mental health problems being addressed? Like, how's public health handling that? And the places that are trying to implement it, are there stigmas attached to that as well?
Yeah, that's a great question. I think mental health problems are one of the least addressed problems in the African continent, in my experience. It's not informed by a lot of data, but maybe that's part of the problem. I don't think we have a lot of data on the prevalence. Also, it's just been my perception that some of the mental health tools are very difficult to adapt to a cultural context. So I'm not sure if our assessments it seems to me it's hard to do assessment in some of these things, and it's hard to do therapy and treatment as well. But I guess on the good side is that maybe they're not as discriminating. You often see people with mental health problems, and they're just part of, society there, and people will feed them, and they're not usually in too good a condition, the more severe mental health problems, but at least they're tolerated by society. But I think from a public health approach, I haven't seen a type of focus on mental health issues as it probably should be. I think it's a really insightful question.
Well, thank you so much for coming, Dr. Wiersma. We're very honored to have you as a distinguished alumni here at Calvin. We really appreciate you coming to talk with us. And we look forward to hearing about all your adventures in the years to come. It sounds like you move every other year, so we look forward to hearing about all the other places you are.